So let's get started. Welcome everybody to Maternal and Infant Health Canada's educational webinar series. Today we are joined by Judy Norsigian and Katie Hassan. Sorry, got that one mixed up. Who will be discussing challenges posed by current ART practices, surrogacy arrangements, and gene editing. Are new public policies needed? It's always wonderful to see everybody joining in. And for those of you who are watching the recording, welcome, welcome. For those of you who don't know us, we are a global public health collaborative working to improve the health of women and children around the world, seeking equity-driven solutions to a more sustainable world. This is achieved through our education, research, and innovation pillars. We're made up of doctors, researchers, public health professionals, and traditional medicine practitioners from around the world. We've also recently joined forces with the Global Women's Health Network, which is comprised of alumni from the Harvard Takemi program in international health. And they are co-sponsoring our webinars. We have recently updated our social media and email newsletters. So if you'd like to keep up with anything that's happening for Maternal and Infant Health Canada, you have a lot of different ways now. So what I'll do is I will add this in our chat box. We have email, which is MIHCAN cares@gmail.com. We have a Facebook page. We have our website, which has all of our recorded webinars, and we even have LinkedIn now, and I believe Instagram. So if you'd like to keep up with us, you're welcome to use any of those platforms. You're also, for those of you internationally who love their WhatsApp, and that's the easiest for them, you're also welcome to get on our WhatsApp list. So you just email MIHCAN cares @gmail.com. At the end, we are also going to be doing a follow-up questionnaire. We'd love to have your feedback on this presentation and our work. So if you've got a minute at the end, I'll be putting that in the chat box because we'd love to hear from you. As with all of our public webinars, I have to add the following disclaimer. This course and handouts may contain general information about medical conditions and treatments. The information is not advice and should not be treated as such. If you have questions during the webinar, we do have a chat box that is active. So if you have questions throughout the webinar, feel free to type them in the chat box. I'll be capturing them and saving them for the end. And at the end, we usually have a more informal discussion where we'll ask the questions. You're welcome to unmute, and we can have a bit of a discussion, which is always a really exciting part of the webinar. As usual, I am your moderator, Emily Solomons. I'm a doctor of traditional Chinese medicine and Maternal and Infant Health Canada's team lead. I am zooming in from the ancestral lands and unceded territories of the Coast Salish people, also known as New Westminster, BC. We also have our amazing Dr. Farah Shroff, who is the founder and lead of Maternal Infant Health Canada and a Takemi fellow at, alumni of the Takemi Fellowship at Harvard University. Our distinguished speakers today are Judy Norsigian, who is a co-founder of Our Bodies, Ourselves. She serves as executive director of the organization from 2001 to 2015 and is the author and editor of each of the 9 editions of Our Body, Ourselves, the organization's landmark book on sexuality and reproductive health. Personal recognitions include honorary doctorate from Boston University in 2007, and being named one of the 21 leaders of the 21st century by Women's eNews, along with a whole host of other amazing things. So we're very excited to have her on today. We also have Katie Hassan, PhD, who is the Associate Director of the Center of Genetic and Society, a public interest nonprofit that works to ensure equitable future where human genetic reproductive technology benefit the common good. She writes, speaks, researches, and teaches about the social and political aspects of the human genome editing and reproductive technologies. Katie earned her PhD in sociology with a designated emphasis in women, gender, and sexuality from the University of California, Berkeley, and was previously assistant professor of sociology and gender studies at the University of Southern California. So thank you so much for tuning in, everybody, and for speaking to us today. Without further ado, I'd like to pass this on and we can hear their presentation on the challenges posed by current ART practices, surrogacy arrangements, and gene editing. Are new public policies needed?
Welcome. Thank you so much, Emily, for that lovely introduction. And we're honored to be here. I'm especially thrilled to be doing this with Katie Hassan, who is now the Associate Director at the Center for Genetics and Society. That organization has one of the longest standing collaborations with Our Bodies Ourselves. Since the late 1990s, we've been working together to address some of the many challenges posed by new genetic technologies. And I am so thrilled to be here and to be doing this with Katie. And I also want to say that though I won't be speaking much about Our Bodies Ourselves as an organization, I do want to underscore that we've embarked upon a new era. Since 2018, we've been largely volunteer driven, and we entered into an agreement with the Center for Women's Health and Human Rights at Suffolk University, which is now operating a new digital platform called Our Bodies Ourselves Today. And for those of you who are interested in learning more about the organization and about this new website, there is going to be a wonderful interview with Robin Morgan at the Women's Media Center this coming Sunday. And we don't even have the exact time yet. I do know it's going to be on Sunday, but what I'm going to do is right now give you the link to the Women's Media Center website, and you can go there and find out when this is going to be on Sunday. I believe it's late morning. You'll hear from two of our current Our Bodies Ourselves board members, Marta Pagan Ortiz, who has been doing an amazing amount of work around gender-based violence, and also Diana Namumbeja Aboye, who is a board member from Uganda who did the original Luganda translation adaptation of the book and goes to Uganda every year or so and recently reprinted the book for use by village women in northern parts of Uganda. So that will be a wonderful chance to hear more about the organization and what we've morphed into in the past 52 or 3 years. So now I'm going to go to my presentation, and I'm going to see if I can get my screen up. Here we go. And I'm going to, okay. I'm going to be talking a little bit about transnational commercial surrogacy and egg retrieval for pay. And I'm not going to say much about the gene editing because I think that will be well covered by Katie, but I wanted to note that these things do go hand in hand, and it's a very complicated space, and it always is challenging for us because we often take positions and a cautionary tone that's also espoused by right-wing anti-choice forces in our society. So we are constantly struggling with making ourselves distinct from these other anti-choice forces who don't really share our overall objectives and perspectives. Okay, let's see now. A little bit about terminology. This always influences how we frame and understand issues and understand issues. These are terms you may know about, but I'm just including them here. And since you'll have this PowerPoint later, you can reference this terminology later. We tend to like to use gestational mother rather than surrogate because of the woman's central role as one of three so-called mothers involved: social, genetic, and gestational. Term gestational carrier is very common in marketing and other literature, and this reduces the gestational mother to a mere vehicle, pouch, or incubator for the baby. We talk about intended parents. These are the people who hire a gestational mother to produce a baby. Gestational surrogacy is this practice of using eggs and sperm from the intended parents or donors to impregnate a gestational mother with the help of assisted reproductive technologies like egg retrieval, in vitro fertilization, and embryo transfer. And this differs from the original traditional surrogacy model. You probably remember the famous Baby M case, which used the gestational mother's own eggs. And this practice is not really in existence much at all today. Commercial surrogacy is the contract-based practice of hiring and paying a gestational mother in a gestational surrogacy arrangement. The commonly used shorthand surrogacy does not highlight the commercial nature of these arrangements. And of course, we like to use the term transnational commercial surrogacy. This is often the case now that we're involving practices and individuals who come from different countries. Egg providers are those women who provide the eggs for other people's fertility treatments or biomedical research as well. Somatic cell nuclear transfer, which we won't discuss today, is one of the arenas in which we have been active. And though we were very supportive of using otherwise discarded embryos for stem cell research, we were opposed to creating fertilized eggs de novo using fertilized embryos de novo using eggs from women who are doing this solely for the purposes of research. And egg retrieval for pay is, in fact, what we see most often in practice today, though there are some voluntary arrangements where people provide eggs simply for magnanimous reasons, out of the generosity, maybe personal relationships. Obviously, ARTs has advanced the treatment of infertility, creating options that never existed before. And at the same time, we've got a host of problems for public health and human rights folks. The growth in ARTs, commercial surrogacy, and egg retrieval for pay is occurring within a profit-driven and mostly unregulated market. That's a challenge. And the primary suppliers are women. That's a challenge. And they supposedly choose to participate, but this is in the absence of health protections, legal oversight, financial guarantees, and mechanisms for redress in the event of negative outcomes. And also, when women are choosing these, shall we say, enterprises because they are so poor and have so few other options, we have to question whether this is truly choice in the way that we conceive of it. Several years back, our group created this website called surrogacy360.org. It's independent, commercial free, and it contains factual information for both intended parents and others. And the website is now managed and operated by the Center for Genetics and Society, and they're doing a terrific job. So this is a go-to resource for anything concerned with surrogacy. So we encourage you to make note of this and use it. There's obviously now an incredibly important intersection between commercial surrogacy and egg retrieval for pay. Both follow competitive market principles with demand from intended parents and profit margins of brokers, agencies, and clinics setting prices of supply. There's no structural motivation to represent or act in the interests of gestational mothers or egg providers. Ensure that one party delivers goods acceptable to the other party, often with minimal contact between the two. And frequently we see that we downplay the health risks to egg providers, gestational mothers, and often to the resulting children as well. And it's highlighting these risks that is so important for those of us in civil society who care about this deeply. And because of the activism of the women's movement in India, commercial surrogacy is now banned in that country as of 2019. The only form of legal surrogacy now is altruistic surrogacy via a close relative. However, illegal operations still function in the country. And here are two important films if you want to see some background information, how activists raise these concerns and some of the ongoing concerns that we see, maybe not in India, but in other countries now. So I've given you the links to these two films. And these are important quotes, one from Sudha Sundararaman. She's with the All India Democratic Women's Association in India. The concept, egg retrieval for pay, is promoted as a way of easy income generation for women. It is no wonder why the private sector is balking at the regulation of assisted reproductive technology. A comprehensive, effective, and enforceable law is essential to safeguard the interests of poor women who are the worst affected by the unscrupulous and unethical practices. And Ranjana Kumari from the Center for Social Research. The business volume of this trade is rising, with the number of surrogacy cases increasing at a galloping rate. The lack of regulation also poses a problem for government agencies to initiate legal provisions and take substantive action against those found guilty. These are the kinds of statements and activism that made a difference in India and why the commercial practice is now not allowed. These are some of our general concerns about surrogacy: a failure to impart evidence-based information or to adopt best practices. We will be soon posting a best practices document at the Our Bodies Ourselves website. It's not available quite yet. The commodification of women's bodies as a means to highly valued products, both eggs and babies, use of marketing techniques and messaging that encourage eugenic decision-making by intended parents. This may include sex and trait selection, co-opting the language of choice and equity to justify the industry's practices, and disingenuously relying on the language of gifts and women helping women. Even when money is involved, you will often see that women who are participating, either as gestational mothers or as egg providers, do believe that altruism is an important part of what they are doing. They're not doing it just for the money. Health risks associated with the retrieval process, still not adequately studied. And these include the negative risks of drugs used to suppress ovarian function, as well as those that hyperstimulate ovaries. And there's often a failure to cancel a cycle when medically indicated. We've seen this in cases when the ovaries have been hyperstimulated, so many eggs produced, and there are examples where other colleagues have said the cycle should have been canceled at an earlier point. Minimal or no collection of short-term or long-term safety data. We're still in a massive experiment. We have not done the long-term safety data collection, especially for these young women who undergo egg retrieval, multiple egg extraction. Little or no access, formal or informal, to other egg providers for emotional support. And I'm going to footnote here a couple of resources. One, which was the Infertility Family Research Registry based at Dartmouth-Hitchcock Medical Center, is not really that active now. It encouraged participants at fertility clinics to contribute information towards long-term safety data on ARTs and egg retrieval for pay. But for the most part, the fertility clinics didn't even put up notice about this voluntary registry. So the participation was very, very limited, and their data collection was limited as well. There is an exciting group called We Are Egg Donors, based in California, but they include a lot of women from Canada as well. And they have been pooling their information and resources about their own experiences being egg providers. And they're conducting in-depth surveys of egg providers along with researchers, social scientists who are interested in working with them. So you should be watching out for what We Are Egg Donors is able to produce. These are just some of the many ads that you see all over the place. In the United States, I don't know about in Canada, sometimes it's a particular ethnic background that's sought. Sometimes payments have been up to $100,000. Usually, you are encouraged to give the gift of life, as they say here. It isn't just about the money. We started, but we never really had the resources to complete an alternative campaign. that would ask young women reading these ads in these college papers to see this ad as well and understand that they didn't know much about long-term health risks. And they maybe haven't asked what kind of care they'll receive if there are complications, who will pay for it, what are the long-term fertility and health risks to egg donors. And we gave here several resources for people who saw these ads to get more information. And then, of course, there's the whole controversy around women freezing their own eggs for later use. I won't say much about that now, but you might remember that Apple and Facebook made a decision to pay for egg freezing amongst their staffers, largely ignoring key concerns that women needed to know about, and mainly concerned about keeping the women in their workforce and encouraging them to delay their fertility, their parenting plans. There are also some risks to children. I won't get into that much right now, but they're children commissioned by intended parents, genetically linked to egg providers, and birthed by gestational mothers. The impact on them include health risks, especially due to a higher incidence of multiples and preterm delivery, and psychological and identity issues downstream. We want to not minimize these concerns. There are some allies now working together, thinking about the intersection of concerns around adoption and surrogacy. And The Hague had an important meeting about 8 years ago, and 100 scholars, activists, and policymakers were discussing ways to improve international standards around evolving practices related to cross-border adoption and surrogacy. Those conversations are still ongoing. These are some takeaways from the Hague Forum, and one of our former staff members and a founder, Sally Whalen, is continuing to work in this space, as is Katie and her colleagues at the Center for Genetics and Society. In the interest of time, I won't read this, but you can look at it later. We are concerned about what international legal and human rights principles, transnational surrogacy and egg retrieval for pay. What practices would satisfy these principles? What international medical standards and principles should be followed in these transnational commercial surrogacy and egg retrieval for pay arrangements? What are the best practices that should be followed? This again is going to be in our document we'll post soon. And the UN had a special rapporteur addressing human rights concerns surrounding these issues, and you can go read that at this UN website. And while not all forms of surrogacy amount to sale of children, this practice, in particular its commercial form with the involvement of for-profit intermediaries, often involves abusive practices in which children are being traded as mere commodities. Several scandals have highlighted the abuses that can arise in this context. And this woman in particular has recommended strict regulation and oversight mechanisms to prevent instances of sale and exploitation of children in the context of surrogacy. And again, another General Assembly resource I refer you to. In New York State, we had quite a controversy several years ago when advocates, including many very privileged gay men, pushed through, and I am including gay men advisedly because many gay women did not participate in this at all, pushed through legislation with their connections to the then Governor Andrew Cuomo that was not in the interests of all parties. And we are going to possibly be working with advocates in New York in the coming year to introduce new legislation that will address some of the problems created by this Child Parent Security Act. We still need protections put in place that will recognize the health and rights of all participants. People often say, as did a recent New York Times article, that we are regulating this practice sufficiently in the United States. We are not. That is a myth, and New York State is an example. And these would be the sample features of a model commercial surrogacy bill, that you would have only single embryo transfer. And many of you have medical backgrounds. I do not need to underscore this. I don't even think you do much multiple embryo transfer in Canada now. You've known this as a bad practice for a long time. only medically indicated cesarean sections for the gestational mothers. Having this as a routine practice is damaging for the mother, the babies, for everyone involved. It was only a matter of convenience that caused this to be put in place. And it was one of the things that highlighted the problems in India, because there was a death of a woman who had one of these planned cesarean sections, and that made the press. Coverage of the gestational mother's healthcare expenses, including some postpartum care, possibly up to 8 weeks, assigning parentage at birth to the gestational mother as one of the legal parents until she relinquishes such rights. This is so important when you look at the legal quagmires we've already seen in these cross-border commercial arrangements. Establishing a mandatory registry to collect safety data and allow for long-term follow-up of egg providers. Information about genetic and gestational parentage being made available to offspring once they reach legal adulthood, and then restriction of technologies such as nuclear genome transfer and CRISPR, and Katie will talk more about this. I'm just closing with this wonderful, public health, I don't know, it is the precautionary principle of public health, which many of you ascribe to, that it's essential to combine this message in an age of escalating commercialism in all sectors of our lives. The absence of evidence of harm is not the same as proof of safety. And with that, I'm going to pass it on to you, Katie, and thank you again for joining.
Thanks so much, Judy. It's really great to work on this presentation with you, and thanks so much for having me here with your group. I'm going to share my screen. All right. So I think Judy's covered so much great ground there, talking about the general issues with ART, egg retrieval, surrogacy arrangements. And I'm going to jump in talking specifically about heritable genome editing, but this is really sort of the juncture between our two presentations here is sort of the place where we're seeing the coming together of a number of human genetic technologies with reproduction. So Judy mentioned nuclear genome transfer, sort of often referred to as sort of mitochondrial transfer or mitochondrial donation. We might also think about the ways that genetic testing is increasingly playing a role, particularly in terms of pre-implantation genetic testing, and even pushing into these new polygenic risk scores that are being offered by commercial companies to that use proprietary algorithms to rank IVF embryos according to predictions about polygenic conditions, and there have even been attempts to say that this could be used for something like IQ or other traits. So that's another sort of place where these technologies are coming together. But where I'm going to focus is on heritable genome editing. And what you're seeing on the screen now are a number of magazine covers that have been published since 2015 or so. That are really sort of showing what the public imagination is of the way that CRISPR and gene editing technologies may come to shape the future of children, and sort of both what is being imagined about the babies who would be produced through these technologies, and also what concerns are coming into the public imagination. But before we start, I also wanted to make a sort of terminology clarification and say that there's a big distinction that we need to make about different kinds of genome editing. So one main distinction is between somatic gene editing and germline gene editing. So somatic gene editing is using CRISPR or other gene editing technologies to alter the DNA in specific types of cells in the body, right? It would be permanent changes, but only to that type of cell in an existing patient. and would not make changes that would be passed on. And so this is the kind of gene editing you hear about in terms of treatments for, say, sickle cell disease that are being developed. But for germline gene editing, we're talking about making changes to the DNA in eggs, sperm, very early embryos in ways that those changes would be copied into all cells in the developing embryo and in the future person that comes from them. And this is an important distinction because of this, because of its potential use in reproduction and the fact that these changes would be passed down to future generations. And within this category of germline genome editing, I want to make a further distinction about not only making genetic modifications to germ cells, but the use of genetically modified embryos to initiate a pregnancy that would result in the birth of a child with a modified genome. So that's what we're calling heritable genome editing. And that is really where CRISPR genome editing comes into play in reproduction, right? It's the use of germline genome editing in reproduction. And so heritable genome editing is what I'll focus on today. And you may have heard in November 2018 from the scientist He Jiankui, who announced the birth of the first CRISPR babies that he called Lulu and Nana. And he had altered the DNA of 2 embryos in order to attempt to make them resistant to HIV. But when He Jiankui made this announcement, he thought that he was going to meet with acclaim and potentially be in line for a Nobel Prize, but he was met with nearly universal condemnation for what he had done. He was criticized for the sloppiness of his science, for ethical lapses in his research and experimentation, but mainly for crossing an ethical red line that scientists and the public had agreed should be off limits. And this was the idea of altering the genes and traits of future generations. So I wanted to talk about some of the concerns about heritable genome editing, starting with safety concerns, right? These are clearly, there are clearly many concerns about the safety of heritable genome editing. There's a range of known risks, including off-target effects, right? Edits that are made at the incorrect spot in the genome, unintended changes that are made at the site that's being targeted. There's been research about the ways that using CRISPR on human embryos can make massive changes that result in what one reporter called chromosomal mayhem, actually the loss of whole chromosomes in the embryo, and the risk that the changes would be made in some cells in the embryo and not in others. But there's beyond that a whole range of incompletely understood risks. What effects will there be in the sort of developmental cascade? What kinds of gene-gene or gene-environment interactions might come into play? And what harms might there be at different stages of development? Are there harms to the women who would carry pregnancies with genetically modified embryos? What about in later generations? And would there be an ethical way to really determine safety over this long term? It's also important to note the thin medical justification for heritable genome editing. Often the case for heritable genome editing is made in terms of sort of preventing the transmission of serious genetic diseases. And often this is called sort of a therapeutic or a treatment. But it's important to note that there is not a patient who is being treated here. It's bringing into existence a baby with or without particular traits. Also that, anyone who knows they're at risk of transmitting a genetic condition can have children who are unaffected by using third-party gametes, and nearly everyone at risk can have children who are unaffected and genetically related to both biological parents using embryo screening, pre-implantation genetic diagnosis. And this practice is not ethics-free. There are really serious questions that it raises about, what lives will welcome into the world, particularly in a context where these decisions are being made in a context of pervasive ableism. But they do not raise these concerns to the same extent as heritable genome editing, which allows even the introduction of new traits. And finally, there are a range of serious societal concerns, which is where at the Center for Genetics and Society we really see the gravest dangers of heritable genome editing. The fact that it could exacerbate inequalities, particularly if it were made available only to the wealthy early on, as we imagine it would be. It could have the effect of seeming to write privilege and inequality into people's genes. It could potentially introduce new forms if genetic modifications purported to be enhancements were made available. And it's important to note that the danger is around the idea of enhancements. We don't want to give too much weight to a kind of genetic determinist way of thinking about about privilege, that we're not saying that these enhancements in terms of IQ or particular talents are genetically determined or would be effective, but even if they are not effective, the idea of them can cause significant harm in society, right? We've seen the ways that beliefs in so-called superior genes and dividing people into categories based on ideas about biological superiority or inferiority can cause significant negative effects in society. And so often the sort of common sense response to that is, well, let's say that we will not use heritable genome editing for enhancement, and we'll only use it to prevent serious diseases. But even this distinction between, so-called therapeutic uses versus enhancement turns out to be very fuzzy and almost impossible to hold, especially at a policy level. We have to think about how are we defining disease or serious disease? How are people distinguishing between disease and disability? There are, a range of genetic conditions that people see as an important part of their identity, of who they are. The disability community sort of reminds us frequently that, we can see these genetic differences as a valuable form of diversity in society, right? Rather than seeing them as a problem that needs to be fixed or edited out, right? We should be fixing access in society and not, individual disabled bodies or people. And so with that context in mind, who would be making these decisions about, what diseases are serious, or, how are we going to make sure that the voices of people with disabilities, who should really be primary in these conversations, when it's often about, their existence, how can we make sure that those voices are heard in this conversation? And then, it's really important to remember that if heritable genome editing were to be allowed and become common, it would roll out in the same fertility industry, the same profit-driven and poorly regulated industry, with all of the issues that Judy was just discussing in terms of the assisted reproductive technologies that we already have, right? So heritable genome editing would roll out in this profit-driven system where there would be incentives to almost prey on parents' desires to do the best for their children by pushing potentially dubious enhancements, by saying that parents need to give their children the very best start in life from conception, right? To really, and this would lean on biases and prejudices that we have in society about which traits and which people and which lives are valued and which aren't, which can lead into what we've called a new market-based techno-eugenics, right? The idea that this is not the 20th century mass scale, top-down or state-driven form of eugenics that we're familiar with, but one that would work through be enabled by the market and work through individual parents' choices that were significantly influenced by the social inequalities that we have already, right? That this would be shaping how parents would make their decisions. So in terms of policies about heritable genome editing, I wanted to share some results briefly of a study that my colleagues, Marcy Darnowski, Françoise Bayless, Timothy Cron, and I published in 2020, a survey of policies around the world on human germline and heritable genome editing. And looking at heritable genome editing in particular, we found 96 countries that had policies on heritable genome editing, or that could be seen as relevant to heritable genome editing. And within those, there were 75 countries that had some form of prohibition. 70 of them were categorically prohibited heritable genome editing for reproduction. And there were no countries that explicitly permitted heritable genome editing, right? So what we saw in this study was a remarkable degree of agreement across countries that heritable genome editing should be off limits, right? And this is what the map looks like of where we find these prohibitions. So it's an important piece of information that often gets left out of these discussions, is the fact that the consensus so far, across the world nearly, is that reproductive uses of genome editing technologies should be off limits, right? And this shows that there is a remarkable possibility for international agreement on this, and the potential for some form of international policy, which is important because, Judy was raising some of the issues that come up with transnational surrogacy. And I think it's important to remember that, this kind of technology isn't something that will stay in, one particular place, right? It's not something where it makes sense for the laws to go country by country, because we're talking about changes to to the genome that is part of, all of humanity, right? We're talking about decisions that potentially affect all of us. And therefore, we need to have some sort of protections in place, particularly considering countries that that don't have the resources, or their priority is not on something like genetic and reproductive technologies in their policy making. And therefore, we need to think about the ways that we might see cases of ethics dumping, where researchers from countries where this practice is prohibited may look for other jurisdictions where they feel they could get away with doing this research. But because I think one thing that is fairly generally agreed upon, both among opponents and proponents of heritable genome editing sort of across the board, is that this is an issue that should not be decided by scientists alone, right? This is something that potentially affects all of us, and therefore we need to have broad discussions that are inclusive and that provide meaningful ways for all of us to have a say on this, right? So all the way back at 2015, the first International Summit on Human Genome Editing ended with a statement that it would be irresponsible to proceed with any clinical use of germline editing unless and until the relevant safety and efficacy issues have been resolved, and unless and until there is broad societal consensus about the appropriateness of the proposed application. And this is a statement that has been repeated many times in many different forms by all manner of sort of international groups and groups of scientists. But it's something that we, need to hold them to account for, right? That there has not been much action in making the kinds of conversations happen that could lead to this form of broad societal consensus. And what we've seen so far is that the conversations have mainly been dominated by scientists and by sort of small groups of bioethicists. And these conversations will tend to focus on those important safety issues and on ideas around risk and benefit that sort of operate on an individual level, but have not really taken seriously the societal context and the potential risks to society that we would be facing with heritable genome editing. So it's extremely important that public engagement and empowerment play a meaningful role in these policy discussions. And that is something that Center for Genetics and Society has been working on, in particular through what we're calling our Missing Voices initiative. That is a way to get the voices and perspectives of civil society advocates and scholars working from a social justice and human rights perspective into these consequential decisions that are being made about heritable genome editing. And we're really at a crucial moment where these decisions are being made. We will see in 2023 the third of the international summits on human genome editing, which do not feature the voices of civil society and social justice that we think need to be at the center of these conversations. So we'll be organizing some events sort of challenging that summit that's coming up in March. So would love to share information about those events later. But at that point, I'll wrap up so that we can get on to some questions. I think it would be great to have some discussion.
Thank you so much. That was very, it's so wonderful to be able to hear these discussions and what's going on and the questions that arise. And I think a lot of times, I know you were both from the United States, and a lot of times the US gets highlighted as when we have these discussions, like as if it's a US problem. I know being in Canada, we boast of having a slightly more conservative approach to donor eggs, to gestational carriers, in the sense that you can't pay for, or you can't sell your gametes, you can't sell the uterus for being a gestational carrier. However, we are almost exclusively dependent on the donor banks from the United States. So all of the decisions that are made in the United States do directly impact us. And so it, it's a disservice to think that it is decisions to be made just individually in each country. I think you bring up some really valid points. So first, I want to say thank you so much. This has been an incredible discussion, and there was a couple of questions that did pop up, and I think Dr. Schroff also has one, but I'll start off by just Sadie Mincroft had asked, could you go into more detail about what long-term health risks you referred to for egg retrieval? Thanks.
Sure. One of the things that's emerged is a pattern of some of these younger women, 5, 7, 8 years later, going on to try to conceive themselves and finding that they're having serious problems. And one of them is an MD MPH in California who has actually been very active, and she's featured in one of these documentaries. She had pretty serious consequences with torsion problems, and she ended up getting immediate medical care, and she was okay. This was actually during medical school that she provided eggs. But then something like 8 or 9 years later, she had major fertility challenges. And when she went to the fertility clinic, this is the interesting part, they said to her, don't worry, we're seeing a lot of women like you who were egg providers when you were younger having problems now, but we can help you. So they were, this is obviously anecdotal, but they were acknowledging and admitting to her that she was not alone amongst egg providers having subsequent fertility challenges. Obviously, the association doesn't mean causality, but this comment that we're seeing a lot of young, women like you, she's in her mid-30s by then, maybe early 30s, I don't quite remember. But she then started to look into this herself. And I do believe, though I haven't followed it more recently, that we are egg donors are following this phenomenon of subsequent fertility challenges among women who had been providers. And it seems to be at, and this is the question, is it happening at a much higher rate than the general population? And, some of the observers think yes, but the final word is not in. The immediate, of course, challenge is that when you hyperstimulate and some of these women have had 30, 40, 50 follicles produced, they are in crisis immediately with ovarian hyperstimulation syndrome. We may have had 1 or 2 documented deaths in the United States because they didn't get care right away. Obviously, if you're observant and you're paying attention, you would catch the problem, you would hospitalize a woman and she'd be okay in the end. The thing that I am most concerned about is these ovarian suppressants like Lupron. Now, leuprolide acetate is not used in a lot of clinics now, but it's used still in some. And there are so many women who have reported long-term problematic effects associated with Lupron not just around these fertility settings or contexts, but in general. And Lupron was used for the treatment of endometriosis for many, many years, less so now, but it was commonly used. And there was a famous doctor in Oregon, Dr. David Redwine, whom you can still find on the internet. And we once got his 300-page report to the FDA. This is probably the physician who used more Lupron in treating women with endometriosis than any other physician in this country. I mean, and the man is probably in his 70s now, at least 60s. And he finally, maybe 15 years ago, I can't remember the exact date, went on what I would call the warpath about getting Lupron off the market. He was so distressed. There are also men, it was used for the end-stage treatment of prostate cancer, and there were many men who reported serious problems. We do not fully understand this whole phenomenon, but for so many women, Lupron has posed not just short-term, but long-term effects, brain fog, neuropathies that don't go away. And the Lupron Victims Network, which I do believe is still available, somebody preserved their website on the Wayback Machine when it got taken down. And I have not watched, gone to visit it lately, but there were so many reports and I saved some of them. I have probably a selection of 2 or 3 documents with 12, 13 pages of direct reports from women who use Lupron. And that remains for me one of the major concerns, that we don't understand long-term health effects of some of these drugs that very powerfully suppress ovarian function. Anyway, that's enough for now, but there are more things that are at the website, surrogacy360.org. You can go and read about it.
I posted, if you go on the chat, I posted the website for those who are interested. That's really, really fascinating, because in Canada, we use Lupron very regularly still. We use it in IVF cycles all the time, and we use it still for endometriosis. So this is fascinating to hear that we are obviously a bit behind in our treatment protocols. And yeah, I'm now very interested to follow up and research a little more into that. So thank you for bringing that up. Dr. Schroff, did you have some questions you want to ask?
Well, I wanted to just really thank the two of you for your the really complimentary ways in which you talked about this problem. It seems like it seems a lot like the situation with so many women's health issues, that there's a majority of people who are really, really concerned that we're doing that we're going in these directions, and yet we're forging ahead with this kind of newfound eugenics. It just makes me think this is like Hitler's wet dream on steroids or something. This is, the kind of thing that those strong men absolutely love, like creating a new humanity and using women who are living in poverty, racialized women and others as the kind of army of people who are going to create this new breed of people they want. And just a practical question for organizations like ours. We're creating a statement right now and a call to action to support the revolution in Iran right now. Can we do something as Maternal and Infant Health Canada? Is there a petition, a statement, a call to action, anything that we can join on to, sign on to? How can we help make the world know more about this and do something differently?
You want to start, Katie?
Yeah. I would say, learning more about the issue is key, and, sharing it with your members. I think having the voices of healthcare professionals in this and public health professionals in this conversation is really important as well. I think, often the assumption can be that, scientists and I'll support this going forward, and it's only sort of conservative factions who are sort of trying to hold it back. And that's not actually the case. There is significant disagreement and concern among scientists themselves. There are very prominent groups of scientists, including one of the CRISPR co-discoverers, who have spoken out against not moving ahead with heritable human genome editing. But I think that, having the voices of medical professionals who would be working with patients who are attuned to as well the kinds of issues that your group focuses on. I just think that is really important to have in the conversation. So, tracking some of these events, like the International Summit that's coming up in March, and asking hard questions about, where are these voices that are expressing concerns? Where is the discussion about justice in the conversation about heritable genome editing? I think that would be a really big contribution.
And I would just add that it's particularly important to elevate and amplify the voices of the disability rights community and women of color organizations who see this whole arena as ripe for advancing institutional racism as well. The eugenics specter is the thing that really sobers me the most. And Katie talked about that so eloquently. This is so easy to slip into because the intersection or the overlap between, just wanting to better your family, your situation, improve the chances of success for your offspring, what I would call very innocent aspirations, they mesh so readily and easily with eugenics agendas. And it's really important to think long and hard about when our personal aspirations might aid and abet institutions that do have a specific eugenics agenda, and we want to be careful not to support that. So it's not so simple, but it begins with educating ourselves, as Katie said, and listening to the organizations and individuals who are most directly affected. And it's why I really think so highly of We Are Egg Donors. And I need to go back and check the website. There are some social scientists working with them now and producing really important information coming from their lived experiences. And that's, our bodies, our cells is all about evidence-based information, but we are so committed to making sure that the voices of women and others affected by all these issues are heard, and they're so often suppressed and ignored.
Thank you so much. Dr. Solomos, may I just ask, we've got Dr. Andy Ugo here from Nigeria, and I'm wondering if he would like to say something.
Hello.
Hi.
Hello.
Hello.
Yeah, my name is Dr. Andy Ugo. I'm calling in from Abuja, Nigeria. So I've gone through the stuff, so I found out that there's more into the discussion than beneath the eye, because in the cases like Nigeria, this sort of surrogate issue and arrangement stuff is more complicated than the beyond the reasonable doubt of the individual. So some individual or some aspect of it tends to understand it by, I need to develop or gain or achieve through surrogates by doing such items and things before I achieve. So not knowing that there's many process and complication issues that comprise this stuff. And then at the end of the day, they find it being alone after going through that process. Because in some cases, majorly cases is just because of poverty issues. So most of the surrogates tends to partake in it. And again, when they get these maybe a plate like a source of income, before you know that they are back to zero. So, and it's a complicated issue in the sense that education-wise, culture-wise, religion-wise, and more of the intellectually to understand what aspect you're getting yourself into before you can accept, on quote, to be a surrogate to a particular certain individual. So in Nigeria, it's more of the complication issue. Yeah, just a lot. So, but there's a solution towards it, but which is, I don't know whether we have reached a solution to discuss solution now, but this is my input for now. So before we can get in more. Thank you.
Yes, you've raised such important issues, and it is so complicated in a country where even if you passed a law that would protect the interests of all parties, it's very hard to enforce it or regulate it. And the fact of poverty for so many women means, of course, they're going to take advantage of a practice that would give them, you know, during one pregnancy, the amount of money they might make in several years doing whatever job. And even in some cases, it's 6 years. We just had an article published in the New York Times this past week about a woman who was a gestational carrier in Cambodia. And the man who had commissioned her was from China. And it turns out he is a gay man. And because of breaking the laws, that man is now in prison. And she has been forced, as an alternative to going to prison herself, talk about blaming these women directly, she was told by the Cambodian government that in order to avoid going to prison, you have to raise the child yourself. And of course, she loves the child. She's actually now, some months later, she wouldn't want to give the child up. She's been with the child for how many months? But the point of her doing this was to have enough money to feed her other children, which she was not able to do. And so she is raising this child. She didn't intend to. The man is in prison. And, you know, she feels very badly for him. He's in prison in China. And it's just one of many such stories that the complicated arrangements and the collision with laws in a country that do not think about the altruism, the needs of the individuals. I mean, it is a mess, to be blunt. And if we don't have in place good practices that will prevent some of these horrendous situations, including children in legal limbo, where they don't have, they can't go from one country to another. There's nobody to take care of the child. The gestational mother can't, and the child is like in some sort of protective custody with no understanding of what its future will be. We have examples of that sort too. So you are right to point out how, you know, complicated and thorny these issues are.
Yeah, thank you for needing that, but there's a lot, education-wise, again, there's a lot most of Africans need to understand before you can get yourself into all these systems. So most of them, because of the intended way your life and your family is being brought up, you tend to be deceived easily by merely talked into, and before you can realize it, you have become a victim or sort of a deal. Like example, let me give you an example. That's something that happened in my hospital. So she's actually a surrogate. We later find out that she's also a surrogate, but she was trafficked from one family to another. So not knowing that she also has a child with her husband. So when she did the third surrogate, because that's the third one she was doing, because we later find out that it was a third one she was doing. And that complication issue with her system and the birth, she let her die. Then in a situation now, the person who's supposed to get the baby received the baby, but did not meet up with his own end, because the agreement was to settle her with use a sum of money and then accommodation and pay the tuition fee of our daughter. So now she's dead. The family collected the baby, and then off they go without paying the ransom and agreement. And now she has left her daughter motherless, and then the father is a widower. So it's like a complication issue, more of the education-wise and more of poverty and stuff. So people need to understand the concepts of this surrogate issue. So we are not saying that surrogate should not be an advantage, or let me use the word advantage, so sorry for using that, but we should understand that it's also a beneficiary in other ways of people looking for children and in all the ways. So, and again, it's also beneficiary to other particular person being a surrogate to understand what she is going into or putting herself into, and the situation she needs to accept before she can give a go ahead of that. Thank you for listening.
No, I think you bring up really good points. I think people like to emphasize, the altruistic side of things, but really having in place the policies that say, well, what happens if there's a miscarriage? What happens if there is a maternal death? What happens if there's, the morbidity and mortality piece into it? What happens if there's complications? And really having that built into kind of an international policy. Dr. Shop had a follow-up question for you, Dr. Ugo. What are appropriate ways to inform potential surrogates about risks in a country like Nigeria?
But actually, that was for anybody, like maybe Dr. Hassan or Dr. Norsigian have an idea on that, like, just because it's just a big question. Like, I've worked and lived in Nigeria, and it's a huge country and highly stratified. And so I can and I have seen women easily talked into doing things that are not in their best interest, and yet because it's a short-term gain and a little bit of money could go a really long way, they're going to do it, whatever and they're willing. Sometimes even if you say, look, this is a potential risk, they're in such a difficult situation, they're willing to take the risk. It's such an extreme situation where women are really pressed. And so, yeah, it's just sort of a wondering out loud. So how can we explain risks in a way that is, that people can hear them really well?
Let me take example. Okay, sorry. You can.
No. You go, sorry. Doctor. You go.
No, let me use my country as an example, because in a situation like ours, a surrogate is gone in between a third party. So before you get a surrogate, there is a third party, like an intimidator, as in mediator between you and the surrogate person. So to my own solution and to my own aspect, education is number one. We need to have a council and understand and consult an expert for you to get to understand the concept of where you're heading to. And number two, if there is any agreement between the surrogate and the person that is getting this, the receiver, needs to be a direct input between the surrogate and the person, not a third party scenario where the third party collects a percentage of salt and the surrogate collects just a penny, which at the end of the day does not work well with her. So, and all this issue is what we in Nigeria, I was talking about, that if you are doing a beneficially based on this is what you want, and you have gotten in your process going through the system and then get exactly the person you want to be a surrogate to, then anything you're doing with the person has to be direct to the person, not a third-party issue. So, and again, an issue of a health issue, then it should be a specific hospital that deals with that particular surrogate mom and must have a history of that particular surrogate, so that at any complication, then it can be indicated before going or moving forward. So that's part of the solution we are talking about: education first, and then going direct with the surrogate subject. Sorry, thank you.
You know, Farah, I think also that the NGOs in all of these countries, and Nigeria has a lot of good women NGOs and public health groups, that I think the NGOs and the public health professionals have to help lead the public education campaign. And it'll be different in different communities. It's different if it's rural, it's different if it's urban, but people who live in these settings know best how to reach other people about important health information. And it's always got to be in the cultural context and done well. And the irony here is that for many women and others engaging in these practices, the religious and the cultural taboos are there, but the money, as Dr. Ugo has pointed out, the money is so badly needed. They will violate their own religious and cultural norms in order to have money to feed their children. And, you know, because survival is in the end the most important thing. So it isn't a simple situation.
Well, I just want to say thank you to all of you. I'm so glad this last part of the conversation felt really important to me, and I'm so happy that you were able to come on video, Dr. Andy, because otherwise what happens is that we start seeing this as a North American issue, and it absolutely is a global issue, right? We really need to be able to see how really women's bodies are being used as battlegrounds in so many ways all over the world, and to stand up against that very strongly. So yes, thank you to all of you. And I really would like to ask all of you if you can fill in the feedback form. We really would appreciate your feedback. We've been sending it in the chat, and we would very much appreciate it if you could fill that in. And I'll now just pass it to Dr. Solomons to say our goodbyes.
Well, yes.
Sorry,
so,
before you said goodbye. Sorry, I'm sorry for coming late because the time I saw 8 a.m. The letter saw 5 p.m. and it was clashing between my work and my stuff. Sorry for barging in late.
Oh, no, we're glad you were able to get in. This is wonderful. And if you missed any part, we'll have the recording up and you'll be able to see the beginning section as well. So yes, thank you both of you for speaking to us. We really, it's such an important topic. It's, as Dr. Schrock mentioned, it is an international topic. It is a topic that really affects all of us around the world, and we need to continue this discussion. We need to scream it from the rooftops and make sure people listen. So I really appreciate taking the time to, out of your busy schedules, to speak to us. I also want to say a quick thank you to Maternal Infant Health Canada's social media team and webinar team, for working so hard behind the scenes to make sure that this got off to such a wonderful start, and for promoting the event, and of course to Healthy Seminars as usual for being our platform and donating this space to be able to host us once again. So thank you very much for everyone tuning in. Again, the post webinar questionnaire is in the chat box. So I think we'll put that in one more time. Oh, there we go. Look at there. It's many times in there. So please fill that out, because your feedback means that we can shift and change to help better represent those of us who are part of this organization, and those of you who are watching the webinars. So thank you, everybody. Have a wonderful rest of your day, whether it's evening over in Nigeria and morning over here on the west coast of North America, and then everywhere in between. So thank you very much, everybody, and have a wonderful day. Take care.
Thanks, everybody. Thanks, Judy.
Thank
Thanks,
you.
Katie. That was amazing. I loved it. Amazing, amazing combination of two powerhouses.
Mhm.
Pleasure to
Yeah.
join you.
Thank you so
Yeah.
much.
Yeah, fabulous. We're super appreciative. Yeah.